This module is entitled Using openIMIS for COVID-19 Response, a Practical Guide. My name is Dr. Julius Migrino, and I will be the lecturer for this module. This module is divided into 7 sections. Each section is discussed in its own video, with this video being part 1 of the lecture series. Please remember to view the videos in sequence to fully understand the contents of the module, as each section builds up on the previous sections that came before it. Let's start the lecture with what this module is all about. This module summarizes the role of openIMIS or openIMIS in responding to the current COVID-19 pandemic and beyond. The module initially reviews the basic functionalities of openIMIS as well as its current global implementation. This is followed by highlighting the role of information systems and digital health solutions in general in response to the COVID-19 pandemic. A deeper discussion on cash transfer and other social protection schemes employed globally, with special focus on South and Southeast Asian countries, is also included. The module then ties up how openIMIS has been used by Gambia's cash transfer program in response to the pandemic. Lastly, the module discusses the delivery systems framework and challenges the reader to create a functional delivery chain map utilizing openIMIS as an enabler of a social protection program. The target audience for the module are leaders of the public health sector, including mid-level managers of ministries of health or their sub-offices, as well as leaders in the private sector involved in humanitarian or public health causes. Most cases discussed are localized primarily in South Asia and Southeast Asian countries. However, the general principles discussed in this module can be adapted by any country. The learning outcomes of the module are as follows. At the end of the module, the participant should be able to summarize the main functionalities of openIMIS, discuss current use cases for openIMIS, discuss the role of digital health technology in the management of the COVID-19 pandemic, discuss social protection strategies used during the COVID-19 pandemic, discuss specific use cases of openIMIS for COVID-19 response, discuss Gambia's implementation of openIMIS for COVID-19 response, illustrate the basic components of a delivery systems framework or a delivery chain, and create a draft delivery chain mapping worksheet on how to utilize openIMIS to address a current or probably hypothetical local or even national COVID-19 emergency response program. Now that we have established some baseline expectations about the module and about you, our participant, please proceed to the next video about Section 1, openIMIS as an open source digital public good. See you there. Welcome back to part 2 of the lecture series. In this video, we will review what openIMIS is, its main functionalities, and why it benefits from being an open source digital public good. openIMIS is a free and open source software that provides a digitized system to link patients, providers, and payers. It originated from a locally designed software in Tanzania as IMIS, or Insurance Management Information System, but it has evolved through multiple iterations and specific use cases globally. Through the support from the Swiss Development Corporation or SDC and the Swiss Tropical and Public Health Institute or Swiss TPH. openIMIS is currently being used in Cameroon, Chad, Democratic Republic of Congo, Nepal, Tanzania, and the Gambia, managing the needs of over 6.3 million beneficiaries. It also has a regional community of practice in Asia, including the Philippines, Sri Lanka, and Cambodia. openIMIS' open source and modular design contributes to the efficient management of health financing workflows through digitization of paperwork, optimization of process performance and transparency, avoidance of traditional cumbersome data tables, saving on licensing or coding fees, and all in all benefiting as a global good. As early as 2018, openIMIS has been recognized as a global good and since 2021 as a digital public good by Digital Square, Digital Public Goods Alliance, and the WHO Clearinghouse. As a global good, this means that the software has fulfilled the following criteria. It is adaptable to different countries and contexts. It is free and open source. It is supported by a strong community, which again is the openIMIS initiative and the openIMIS Community of Practice or COP. It is funded by multiple sources such as the Swiss Agency for Development and Cooperation or SDC in Switzerland, Digital Square USA, and the German Federal Ministry for Economic Cooperation and Development or BMZ in Germany. It is designed to be interoperable in accordance with industry standards for information exchange using HL7 FHIR or FHIR specifications, which is a standard for exchanging healthcare data. And among other electronic medical record systems, it is also interoperable with the world's largest health management information system, the HIS2. The target users of openIMIS are institutions who are paying for healthcare services, including ministries of health, as well as public and private health insurance providers. But why would a Ministry of Health, health insurance leadership, or health service provider opt to use a digital public good such as openIMIS? The advantages of openIMIS, along with other digital public goods, include being in the market for a time, being scalable, being adaptable to local needs, for example, being flexible and customizable, are continuously being updated in line with industry standards, have a comprehensive community of support and practice, share international standards for communication, and not being locked to a single software provider. Moreover, initial investment is less than developing an information system from scratch. All these advantages mean that openIMIS can be deployed quickly in a resource-capped locality or country where immediate needs arise, for instance, during humanitarian crisis. Prior to the COVID-19 pandemic, the current use cases for openIMIS are for health financing and social protection, with health financing being its primary function. The key features of openIMIS revolve around functionalities that support health financing, and these functionalities include the following. Number 1, registration and beneficiary management. openIMIS facilitates the digital registration of individuals or families as well as the enrollment of specific beneficiaries to an insurance scheme. This includes gathering of basic demographic information from the beneficiary, then providing them with a member ID card. The registry also contains the member's historical contributions to the policy. Beneficiary management is usually done by an enrollment officer. Number 2, claims management. Enrolled beneficiaries can make health service claims, for example, outpatient consultations with specific laboratory tests, which can then be processed by claims administrators. Number 3, claims review and approval. Once a claim is submitted, it is reviewed by a medical officer. Inconsistency of claims as well as other feedback can also be included using this particular function. The medical officer is also in charge of authorizing payment or reimbursement to the healthcare provider or the facility for the services rendered to a particular patient. Number 4, service providers and services management. openIMIS serves as a virtual stockroom of health services. For example, outpatient consultations and even medical items. For example, COVID-19 vaccines, which are available in different localities from different registered health service providers. This virtual stockroom is maintained by specific administrators, for example, health facilities administrators or medical services administrators. And under this function, availability and the prices of health services and items can then be managed. Number 5, monitoring and reporting. All registries and transactions are stored in the openIMIS server instance, which promotes facilitation of monitoring and reporting under specific functionalities. These include generation of reports such as claims reports, contribution collection reports, product sales reports, and even families and insurees overview reports. This function is generally restricted to specific administrators or program managers. Number 6, administration of registers. This function is the backbone of openIMIS. Under this function, super administrators can assign the different information system roles needed to make the health program functional. These include the aforementioned roles as well as other roles such as scheme administrators or managers, and even program clerks and accountants. As of May 12, 2022, openIMIS is currently adding an AI-based claims adjudication feature to help in the claims review process, and this feature will be added into future openIMIS versions. At present, openIMIS is being used as a community health fund software in Tanzania. In Nepal, it is also being used as the national health insurance system. In this country, new members are provided with a unique QR code. This code contains their membership information provided during the enrollment process. In 2017, provincial health officials in South Kivu in the Democratic Republic of the Congo wanted to revive and strengthen their mutuelles, their community-based health insurance schemes that aim to serve their rural and underserved areas. Together with the support of global partners, openIMIS was implemented in 8 health zones within the province, able to enroll more than 20,000 beneficiaries and contracting 85 health facilities. While connectivity remains a problem in some areas in South Kivu, as with a lot of rural areas in developing countries, the staff of the mutuelles plan to use an offline version of openIMIS wherein enrollment officers would go from village to village and they utilize smartphones and tablets to enroll new beneficiaries and collect their contributions on the spot. Another example of openIMIS use case is in Cameroon. The Roman Catholic Church of the Bamenda Church Province, in cooperation with the Swiss Tropical and Public Health Institute, has set up a health assistance scheme in 5 dioceses within the region, called the Bamenda Ecclesiastical Provincial Health Assistance, or BEPA. This includes micro health insurance schemes as well as HIV fee elimination services. openIMIS can also be used in strategies for social protection, such as for employment injury insurance schemes, or EIIs. Similar to a national or a community-based health insurance scheme, EII can help employees with simplified and more efficient access to benefits in case of work-related injuries. This is also beneficial for employers, health facilities, and scheme implementers, as EIIs also translate to better coordination while reducing operational and logistic costs. Nepal has been implementing an EII scheme using openIMIS since 2019 through its Social Security Fund, servicing more than 130,000 employees and 11,800 employers. That ends part 2 of the lecture series. In part 3, we will discuss digital health solutions employed during the course of the pandemic. See you there. Welcome back to part 3 of the lecture series. In this video, we will discuss how the COVID-19 pandemic has triggered governments worldwide to employ or enhance digital health technologies to support their health systems. The World Health Organization declared the COVID-19 pandemic in March of 2020, and as we all know, this pandemic is caused by the severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. Due to increased globalization, the virus spread exponentially from China and eventually crossed international boundaries. The pandemic caused massive disruptions to the health systems and economies of many countries, particularly developing countries in Asia and Africa. Aside from the financial and logistical disruptions, though, the pandemic has also caused many COVID infections and deaths. As of July 2022, there have been more than 570 million cases, including more than 6.3 million deaths globally. Realizing the need to quickly address the health system issues brought about by the pandemic, different countries have employed different digital health technologies or DHTs, usually in tandem with their existing health systems infrastructure. Such DHTs include telemedicine, electronic health records or EHRs, hospital and public health information systems, systems for tracking of transmissions, mobile health, artificial intelligence, and predictive analytics. Telemedicine and electronic health records are the most frequently used technologies. According to multiple studies, some of the main functions of telemedicine during the COVID-19 pandemic include the following: provision of healthcare service to COVID-19 patients, especially in resource or manpower depleted areas, screening of COVID-19 suspects, and developing and or testing the feasibility of a virtual care program for self-isolated outpatients, inpatients, or even the post-COVID recovering patients. EHRs, on the other hand, have been used as protocolized triage systems, which include case reporting systems, integration with diagnostic laboratories, electronic medical records, and even social media on mobile devices. Some EHRs were also used to integrate recent travel histories into centralized national health databases. A scoping review identifies artificial intelligence or AI and big data as other top technology domains used against COVID-19. In this study, AI has been identified to be used mostly for case management, for example, in the diagnosis of COVID-19 in chest CT scans, while big data primarily was used for surveillance strategies, mainly at points of entries, for example, in airports or seaports. Mobile technologies such as mobile apps, activity trackers, and wearable devices have also been used in COVID-19 response. In a systematic review, mobile apps and wearable devices have been used for contact tracing, while mobile apps have been utilized for patient self-assessment and even self-monitoring, and sometimes even peer-to-peer patient psychological support. As with any new or repurposed technology, utilization of DHTs for specific contexts have their own limitations and barriers. The most common identified barriers are mainly centered on two things: allocation of resources and participation of relevant stakeholders. Resource reallocation to DHTs and supporting IT infrastructure, especially when scaling up is done rapidly or in cases where digital strategies are built from the ground up, poses a burden on the already stretched out budgets for COVID-19 response. In terms of stakeholder participation, one of the main barriers is unwillingness of clinicians, patients, and caregivers to actually adopt new DHTs, either due to limited telehealth training, lack of technical support, unavailability of standardized guidance for digital health services delivery, or interference with current patient-provider relationships. Another stakeholder barrier identified was the lack of access, especially in developing countries. This includes unavailability of smartphones or computers, as well as poor or unstable internet services. In some cases, even lack of electricity. Despite the variability of use cases, the still evolving research on monitoring and evaluation and the inherent limitations of specific digital approaches, the utilization of DHTs invariably contributed to each country's management of the pandemic in multiple fronts, from clinical and diagnostic to community-based and public health strategies. That ends part 3 of the lecture series. In the next part, we will focus on how cash transfers are used during an emergency. See you there. Welcome back to part 4 of the lecture series. In part 4 of the lecture series, we will discuss one of the most common strategies employed in social protection, particularly in a crisis scenario: the cash transfer. Social assistance is the most popular type of response in the context of most crises, a well-known example of which is the cash transfer. Cash transfer is designed to provide a fixed target population with rapid, usually financial resources to aid them during emergency situations. More than a billion people have benefited from some form of cash transfers during the COVID-19 pandemic, and this strategy has protected them from extreme poverty. Families with cash flow are more likely to be able to access essential needs and services, have access to proper health care, enable protection or recovery of livelihoods, and maintain human capital investments such as ensuring continuing education, especially of children. Cash transfers are not new and definitely not only limited for the current pandemic. Examples of cash transfer programs pre-pandemic include Pakistan's Benazir Income Support Program or BISP, which is Pakistan's current flagship social protection program, the Philippines' Pantawid Pamilyang Pilipino Program or 4Ps, which is the Philippines' flagship safety net program, and Sri Lanka's cash transfer component of the Samurdi program. Other countries in the region, such as Indonesia, Malaysia, Thailand, and Vietnam, have their own fiscal stimulus packages. Historical lessons on social protection instruments, such as cash transfers, include the necessity to account for the newly poor, informal workers, and immigrants, the importance of leveraging existing social protection and complementary programs for new or expansionary programs, and prevention of added administrative burden by introducing new programs. Talking about these lessons, it has been noted that the COVID-19 pandemic has threatened or destroyed the livelihood of some 1.6 billion people from the informal sector of the workforce. In response to the massive economic burden brought about by the pandemic, more than 130 countries have implemented more than 350 social assistance programs, with more than a third being cash transfer. This equates from 12% of monthly GDP per capita in high-income countries at least, to as high as 36% in low-income countries. For instance, Indonesia's National Economic Recovery Program has dispersed at least one form of social assistance to over 85% of households, majority of which were cash transfers and the poorest households receiving the most assistance. This included the Program Keluarga Harapan or PKH, a monthly conditional cash transfer program which covered 10 million families from the poorest 25% of the population. Pakistan's ESA's Emergency Cash or EEC program delivered a one-time emergency cash assistance to sustain almost 17 million families for 3 months. In Thailand, the pre-pandemic child support grant, which initially started way back in 2015, received an emergency top-up during May to July of 2020, helping an estimated 1.4 million beneficiaries with their growing expenses such as buying of face masks and hand sanitizers and paying for their children's education. Now let's go to Cambodia's ID Poor program, which aimed to provide temporary assistance to more than 560,000 poor households. This COVID-19 cash transfer program, which included the newly poor people, ran in parallel with existing cash transfer programs. For example, programs for poor or pregnant women, children 0 to 2 years old, and even school scholarship programs. And these payments were usually given through mobile banking service providers. Even a high-income country such as Singapore has implemented one-off cash payouts during the early part of the pandemic, with all Singaporeans receiving between 300 to 600 Sing dollars directly into their bank accounts as part of the country's solidarity budget. Challenges such as increased disease transmission, local and national lockdown measures, and implementation of restrictions to movement and business operations, for example, social distancing measures, curfews, or bans on mass gatherings, these have all affected the implementation of social protection schemes during the pandemic. Governments and other implementing agencies had to adapt their current cash transfer operations and additional emergency assistance programs to navigate through all of these different restrictions. Such adaptations include increase in hygiene and safety protocols at contact points, facing the merging or extension of payment schedules, utilization of mobile money payments instead of in person cash transfers, waiving of program requirements in some or restricted areas, and simplification of enrollment procedures. As part of the lessons learned from previous global crises, the economic stimulus response to the COVID-19 pandemic provide an opportunity to expand social protection coverage. For instance, by increasing benefit levels, extending the duration of programs, and inclusion of more vulnerable or the newly poor groups. One case study in the implementation and ensuing challenges of cash transfer schemes in Southeast Asia is the Philippines Social Amelioration Program or SAP, enacted under the Bayanihan to Heal as One Act. The program aimed to deliver about 100 to 160 US dollars cash assistance to more than 75% of families, or about 18 million households, including the beneficiaries of the already existing 4-piece program. This program was tasked to the Department of Social Welfare and Development, or DSWD, in collaboration with the local government units, or the LGUs. Currently, this program ran under two phases or tranches called SAP 1 and SAP 2. According to a study, SAP 1 experienced significant delivery challenges, especially to new beneficiaries, that is, beneficiaries who were not part of the 4Ps. Because of these challenges, SAP 2 introduced several changes which included the digitalization of the processes. If you look at the table on screen, you can see some of the challenges, mitigation strategies, and lessons learned from both SAP 1 and SAP 2 implementation. Other key implementation lessons learned include the significant roles of number 1, the Central Bank of the Philippines or Bangko Sentral ng Pilipinas in the implementation of SAP 2 through facilitation and arbitration in the engagement of financial service providers or FSPs. Number 2, improved confidence of both the main program implementer, in this case DSWD, and the beneficiaries following the shift to digital payments. Number 3, the recognition of the need for better information management systems and coordination, particularly between DSWD and the FSPs. And number 4, improved and enhanced grievance reporting systems, which we will be talking about again in a future video. That ends part 4 of the lecture series. In the next video, we will discuss a specific example on how one country used openIMIS to implement their COVID-19 emergency cash transfer scheme. See you there. Welcome back. You've now reached part 5 of the lecture series. This part of the lecture series will discuss how the Gambia used openIMIS as a tool for their COVID-19 emergency cash transfer scheme. This video covers a detailed description of the NAFA program, a social assistance project launched in the Gambia using openIMIS. The project is a short to medium-term component within the bigger Gambia Social Safety Net project, which is funded by the International Development Association. The NAFA program was launched in September 2019 by the National Nutritional Agency, or NANA, with the original aim of providing unconditional cash transfers to the extreme poor for 3 years, covering about 170,000 individuals in the poorest districts of Gambia. The Gambian authorities contracted the services of 2M Corp, a local startup software development company, to design and develop the software modules of the Management Information System, or MIS, for the NAFA program, as well as to provide technical assistance to NANA for the project implementation teams to manage and eventually operate the system. The NAFA MIS modules include the registration of households, enrollment of eligible households, management of benefit packages, payment of benefit packages, and reporting. When COVID-19 hit the country in 2020, The NAFA project was revised to respond to the need for immediate temporary cash transfers to affected households. The NAFA project had to be expanded with a 4-month sub-project called the NAFA Quick. This quasi-universal cash transfer scheme aimed to address the economic impact of lost jobs and income and stay-home orders in an expedited manner, targeting July of 2020, which left 2M Corp only about 4 weeks to develop the necessary MIS. 2M Corp decided to use openIMIS to develop the NAFA Quick MIS upon learning of its functionalities. Some of the reasons for utilizing openIMIS as cited by 2M Corp include the following. openIMIS is open source. Information technology specialists are expensive and difficult to recruit in Gambia. Hence, 2M Corp decided to utilize open source technology whenever possible rather than, quote, reinventing the wheel, unquote. openIMIS has been implemented and working elsewhere. 2M Corp researched existing open source systems doing something similar, which led them to openIMIS. And the third reason was that openIMIS had available technical and community support. 2M Corp was able to call on the openIMIS online service desk as well as a heterogeneous community of users, the so-called openIMIS Community of Practice or COP, for help. As 2M business partner Momodu Jarju said, "You can save time, human resources, and money by bringing in something that's already working elsewhere. The client will spend less and they will get the benefits of an open source platform. It's already doing 80% of what you want. The other 20% you can customize." Aside from NANA and the implementing agency, openIMIS as the management information system and 2M Corp as the software developer and technical guide, the implementation of the NAFA Quick program involved a lot of other moving parts and actors. Gambia's Department of Community Development and Department of Social Welfare were other government agencies tasked to partner with NANA in the program's implementation. For the initial list of potential beneficiaries, the program utilized existing rice distribution COVID-19 emergency response data collected by the National Disaster Management Agency. International development actors such as the World Food Program, United Children's Fund or UNICEF, and the European Union were also involved with NAFA Quick. This table summarizes the 4 NAFA Quick MIS modules and their main functions, comparing them with the functionalities of the original openIMIS as discussed in Section 1. In the implementation of the program, the initial list needed to be cleaned and duplicates removed. The registration form was built using Kobo Toolbox, another open source software used for data collection in humanitarian events. This allowed further registration of individuals and households not included in the original list, as well as collect other missing but relevant data from existing databases. Using the beneficiary registration and management module of the NAFA Quick MIS, data from the registration forms were imported to the program where households were enrolled to specific benefit packages by enrollment officers. These packages were then crafted within NAFA Quick MIS program management module by program administrators. Enrollment lists were then processed within the payroll management module by scheme supervisors, and payroll lists were created by scheme officers. Once approved, the payroll lists were shared to payment service providers for disbursement of funds. Payroll reports from PSPs were also imported to the MIS for data reconciliation. Lastly, the NAFA Quick MIS reporting module generated multi-format reports for program monitoring and assessments, and also utilized the data from the modules to show important program metrics such as, for example, total registered households and the number of beneficiaries by region, all on the MIS dashboard. Despite the short time given to develop the system, 2M Corp was able to develop the customized NAFA Quick MIS system using openIMIS modules. The program was run successfully. providing cash transfer benefits to over 78,000 households in 30 of the poorest districts in Gambia within the critical lean season. By the way, the lean season in Gambia are the months where food staples such as rice are in short supply. Usually running around the months of June to October, this coincided with the onset of the pandemic in the country. Hence, the NAFA Quick program was implemented during this time, and the expedited nature of implementation was very crucial. Implementation during this time allowed vulnerable population groups to access basic needs during the most crucial time of the year, while avoiding adverse coping mechanisms such as distressed sales of assets, and also helped keep the Gambian economy running. At the end of the program, Gambia is still keen to use openIMIS for the regular NAFA program health insurance scheme. That ends part 5 of the lecture series. The next lecture video will run through how any country or locality can use openIMIS as their tool for emergency response, using cash transfer as a focal point. See you there! Welcome back to part 6 of the lecture series, the longest segment of this lecture. In this video, we will go into a bit more detail on how to use openIMIS as a system in a crisis situation, say the COVID pandemic. We will be focusing on what we've learned from the previous sections about the functionalities of openIMIS, the resource and logistical needs of the pandemic, and cash transfer schemes for social protection as building blocks of our exercise in this section. If you are ready, then let's proceed. The COVID-19 pandemic was a wake-up call to most governments for an urgent need to deliver emergency assistance efficiently around the world in order to mitigate health, societal, and economic impacts of the pandemic. This section of the module focuses on openIMIS functionalities beyond health financing and builds up on the cash transfer experiences of multiple countries, as discussed in Section 3, to develop a general guide on how to utilize the software to aid in COVID-19 emergency response, specifically for quick and effective cash or kind transfer schemes. This section of the module will utilize the Delivery Systems Framework, or the Delivery Chain, from Lindert et al. 2020, to look across the 4 delivery stages and the specific steps within each stage. The framework is composed of 9 phases within 4 stages. The different phases in the delivery chain shall be discussed in the next segments of the video. We will also integrate these 9 phases with specific functionalities of openIMIS, as outlined in Section 1, that can aid in each specific phase. Aside from discussing the framework and its components, and openIMIS functionalities and its components, this section will also require you to answer specific guide questions. You are suggested to think of a real or hypothetical COVID-19 or otherwise related scenario in your own country or even region or own locality where cash or kind transfer is necessary and an information system would be beneficial in order to provide aid to target beneficiaries quickly, efficiently, accurately, and without tapping into limited resources too much. By answering the guide questions and going through the examples in this section, you should be able to create a delivery systems model for the envisioned use case scenario. While going through the video, you can make use of the full delivery chain mapping worksheet, including a column to specify and identify agencies, actors, and roles that are needed in each phase. This template can be found at the appendix of the reading material document for this particular lecture series. For the purposes of discussion, we shall use the following scenario. We will play the role of a government agency head in the hypothetical middle-income city of Arda. Due to a sudden spike in COVID-19 cases and hospitalizations, the local government of Arda opted to put the city in strict lockdown for 2 months. All non-essential travel to, from, and within the city are essentially put on hold. Mass gatherings are banned, residents are advised to stay in their homes except to buy essential goods, and only commercial establishments providing such goods are allowed to partially operate. A specific vulnerable sector of Ardanians, or the residents of Arda, need money for essential supplies during the lockdown. This sector includes transport workers, such as bus drivers and train operators, small enterprise owners who had to shut down their operations, and the poorest residents who are part of the informal workforce. The target Ardanians are geographically located in multiple sectors of Arda. There is no available centralized database of their names and addresses, but some groups have their own local listings. For instance, bus operators have their employee register. We are then tasked to create an emergency cash assistance program for the target sector in the most timely, efficient, and cost effective manner. We'll call this the ARDA Cash Transfer Program. The national government has already made the funds available for disbursement, and relevant government agencies were tasked to support the program. We decided to use the delivery systems framework from the previous slide to help create a process flow for the program. Guide question: what is a real or highly probable scenario in your country or locality that necessitates cash or kind transfer to targeted population groups? This will be your use case. The outreach phase of social protection delivery systems answers the question: how do people become aware of a social protection program, its rules and delivery processes? This phase has three main objectives: to provide relevant information to the target population about the existence and mechanics of the program. That is, what is the program all about? Number two, to facilitate understanding of the delivery processes and actors involved in the program. That is, who are involved and what are their roles and how will they implement the program. And number three, to facilitate understanding and access to specific enablers of the delivery system. What resources are to be used by the program? There are several methods to implement this phase depending on the social context and environment. Ad hoc offices, kiosks, or even mobile teams can be used to disseminate on-demand information. Community figures such as tribal heads and religious leaders can also be used, as well as intermediary organizations such as schools, shelters, and even foundations. Of course, more traditional mass media such as newspapers, TV and radio broadcasts, and even social media can also be used for this phase when available. It is also worth noting that this phase is often neglected in the implementation of social protection programs, which may result in poor turnout of registrants and subsequent confusion in the succeeding parts of the delivery chain. As a real-life example of Phase 1, Pakistan's BISP communications team did pre-implementation studies to determine their target beneficiaries' characteristics and behavior. They discovered that their target population were mostly non-literate and poor and relied heavily on non-verbal visual material, word of mouth, and vernacular informal communication channels. Now, given these findings, BISP leadership formed committees with community leaders, and announcements for the program were coursed through traditional communication channels. These included town hall meetings, mosques, street theater, and even automated voice calls. In the Philippines, the DSWD developed an active census sweep or house-to-house strategy to implement their outreach and enrollment phase, which they termed listahanan. They utilized mobile teams on small boats and other adaptive transports to navigate through the archipelagic and mountainous terrain of the country. Part of Gambia's NAFA program messaging were delivered actually via radio instead of in person. Guide question: in your specific use case, given your existing communications infrastructure and beneficiary characteristics and behaviors, how can a newly formed delivery system program be efficiently propagated? Let's look at how we can use openIMIS for our hypothetical case in the city of Arda, specifically for Phase 1 of our Arda Cash Transfer Program. The need for rapid information dissemination at this early stage in the ARDA program requires established communication lines. For this phase, openIMIS may have limited direct functionalities. However, it would be beneficial to include in the outreach communications that openIMIS or even any electronic management information system, will be used in the delivery processes for the program just to clear up expectations from the beneficiaries. Prior to or during the outreach phase, the openIMIS administrative processes, such as delineations of tasks, organization of users, and permissions, should also be established. The main objective of the next two phases of the delivery chain is to ensure that the target beneficiaries are registered and profiled efficiently, accurately, and with transparency. These phases answer the question: how will the intended beneficiaries apply for the program? And how are the needs and conditions of registrants assessed for eligibility to programs? The primary output of Phase 2 is complete and verifiable information from the applicants, while the output of Phase 3 is the assessment profile of all the registrants. There are several methods for intake and registration which depends on factors such as geographical location, educational status of target groups, and availability of reliable transportation, electricity, mobile, and even internet services. The figure on screen is a good summary infographic of some of the most oft-used client interface modalities. Key considerations during this phase include identification of intake modality, or who initiates first contact. Is it on demand, administrator driven, or a combination of both? Another consideration is identification of registration modality, or how the registration process is conducted, using which information system. Are you using paper-based, paper to digital, or purely digital methods? Offline and online storage is also identified here. Another consideration is ensuring client interface is human-centered and follows the keep it simple or do simple well paradigm before adding complex functions and processes. The next one is focusing on people as the first mile in the delivery chain. Well, first mile is a delivery systems and supply chain concept and refers to goods and services being delivered from the origin to usually a distribution center or the first leg of the delivery journey. The next consideration is clear identification of each beneficiary unit, either an individual, a family, or households. Now, the last consideration is the provision of multiple points of contact whenever possible. High-income countries such as the United States, United Kingdom, Netherlands, and Iceland have high utility of digital and online intake and registration modalities, which may not be feasible or available in low-income countries. The Philippines' listahanan was conducted mainly through door-to-door census sweep approach, which initially used paper-based questionnaires but were eventually complemented by tablet and laptop data submission. This list was also eventually used during the COVID-19 cash transfer scheme. Oftentimes, social protection programs utilize existing social registries and databases complemented by on-demand application schemes. For instance, Sri Lanka's COVID-19 emergency cash transfers automatically registered recipients of other social protection schemes, while local on-demand registration for specific groups, such as daily wage earners and bus drivers, were also made available, especially those who were not previously captured by the other lists. In most cases, effective and interoperable social assistance information systems that offer remote registration are critical program enablers. Assessments of needs and conditions for eligibility of social protection programs also have different approaches depending on the program's goals and target groups. Such approaches include demographic categorizations, socioeconomic assessments, for example, income testing or proxy means testing, employment profiling, and social risk assessments. Existing government and social protection databases have their built-in assessment metrics, but these lists can be used for new use cases such as identifying vulnerable households who are not benefiting from an existing support program. Program managers can also tap the private sector for independent monitoring of assessment processes. In one of Thailand's social protection schemes, exclusion of digitally naive groups were mitigated by engaging civil society groups to support registration. Guide questions. In your use case, what would be the best or most feasible intake and registration modalities to utilize? What assessment strategies should you implement to verify the list of beneficiaries? And which existing registries are available to help implement the program? Going back to our ARDA cash transfer program, the target Ardanians probably have a diverse range of socioeconomic backgrounds which would need a multi pronged approach. Intake and registration can be done through on demand registration kiosks using digital technology and door to door mass registration for those with poor technology access. Assessment can be based on worker lists from transport companies, business permit databases for small enterprise owners, and existing lists of indigents from welfare agencies. openIMIS basic functionality of applicant registration will prove useful, while its monitoring and reporting capabilities will enable program managers to quickly adapt to timely information as they are collected on the fly, such as the coverage. We will also use the administration function to designate registration officers. Moreover, openIMIS modular design enables implementers to simplify their client interface and avoid complicated but unnecessary features. And openIMIS commitment to interoperability enables the software to communicate with pre-existing registries such as, for example, national identification systems. After registration of the target population, determination of eligibility for and enrollment to specific social protection schemes are conducted by comparing the registrants' profiles to clear eligibility criteria. During this phase, it is also important to define the assistance unit, whether individual, family, or household. In this phase, eligible registrants become beneficiaries. This phase answers the question among the registrants who are eligible to receive specific benefit packages. Several strategies to determine eligibility criteria exist. Of course, as with previous discussions, these strategies would depend on the goals of the program. Some examples of eligibility determination include simple demographic criteria, for example, all persons over 65 years old. Also, poverty thresholds, for example, absolute versus relative poverty, and even employment history or status. The Philippines SAP2, in part, utilized geographical eligibility criteria to provide support to areas disproportionately affected by the pandemic. Indonesia uses its social registry, the Unified Database or UDB, to determine social program eligibility. It uses relative eligibility thresholds per household ranking to determine who qualifies for different programs. Additionally, the country's National Economic Recovery Program in May of 2020 included micro, small, and medium-sized enterprises in their benefits package. To be eligible for loan interest subsidies, for instance, MSMEs must have valid tax numbers, have a good history of loan repayments prior to the pandemic, and have not been blacklisted by their financial services agency. Guide question. Considering the resource allocation for the program and the population demographics, what eligibility criteria would you find to be most justifiable? Since the ARDA program identifies 3 target population groups, the eligibility criteria for each group should be clearly defined. openIMIS has a robust group or family insuries and policies function, which is under the beneficiary management functionality. And under this function, the registrant's profession, poverty status, and other relevant information, which is usually gathered during Phase 2, can be used for a tiered eligibility, enabling administrators to add specific insuries to tiered benefits depending on their individualized condition. Additionally, the administration function should again be used to designate the role of enrollment officers. The next phase in the delivery chain is determining what benefits and or services each eligible beneficiary will receive. That is, which specific benefits and service packages available will be received by each beneficiary. This can be in the form of cash, kind, or services, for example, vouchers for prenatal checkups, or a combination of any of the three in the form of packages. Different case scenarios would necessitate different benefits and service packages depending on the need of the population as well as the resources available in the locality or country. As discussed in Section 2 of this document, cash transfer is a common benefit package implemented by multiple countries during the COVID-19 pandemic. Another often neglected phase in the delivery chain is the notification and onboarding of all registrants. This phase answers the question, what is the current status of each registrant of the program? This phase involves regularly monitoring each registrant whether they are enrolled, waitlisted, or ineligible. Enrolled registrants are those deemed eligible to receive benefits. Waitlisted registrants are those deemed eligible but still awaiting further resources or further assessment. Ineligible registrants are those who are not eligible for any benefits whatsoever, even though they are already registered. For those who are enrolled, the type of beneficiary package that they will receive should be included in the notification as well as how, where, when, and through whom they will receive the package. During this phase, the communication channels as well as the implementing agencies should be clearly defined and oriented. Common notification channels include in-person notification, formal letters, emails, SMS, and notifications within online accounts. Additionally, for those enrolled, onboarding steps are conducted to orient and prepare the beneficiaries to participate in the program. Common onboarding strategies include provision of onboarding kits containing printed program materials, logbooks for monitoring and benefit cards, and even in-person one-on-one or group orientation sessions. Take note that we are using the term registrant instead of enrollee or beneficiary. All registrants should be notified of their program status. In fact, for those who are waitlisted or deemed ineligible, it is recommended that the basis for the decision and instructions for appeals and grievances be included in the notification. Guide questions. In your use case, what benefits or services or a combination of both are available for the target beneficiaries? What are the most effective notification and onboarding strategies that can be done for the program, and who will be the primary actors in charge of notification and onboarding? Aside from cash transfers, another common benefit and service package is through public works programs where eligible beneficiaries are given cash or kind packages in exchange for short or medium-term employment during public works activities. India's Mahatma Gandhi National Rural Employment Guarantee Act is an example of this program, employing more than 70 million persons a year for an average of more than 40 days. Other forms of service packages include social services, for example, parenting classes, substance abuse screening, and disabilities packages, for instance, income support, rehabilitation, or employment opportunities. As further examples, Sri Lanka's COVID-19 cash transfers included the elderly and those with disabilities and comorbidities, while Thailand's existing child support grant received an emergency top-up for 3 months during the pandemic. During the implementation of the Philippines SAP-2, notifications were done through SMS and local government agency offices. Pakistan's EEC program beneficiaries received updates on their eligibility status through a web portal. In Cambodia's COVID-19 cash transfer program ID Poor, some people received news of their eligibility through direct home visits from the village commune authorities following on-demand requests for assessments. Indonesia's conditional cash transfer program PKH entailed an extensive onboarding process involving district coordinators, facilitators, operators, and village officers. The process included explaining the objectives, the rules, and the schedules of the program, affirming the rights, obligations, and conditionalities or commitments and consequences of the beneficiaries, and explaining the grievance mechanisms. As part of the Philippines' experience using SMS, some of these notifications were often met with suspicions of scams. One factor for this is the absence of a standardized notification template. This experience also highlights the importance of phase 1 or onboarding, wherein telling people to expect SMS notifications for updates on their registration status will be happening. As for our scenario, the local government has already identified the benefits and service packages for the ARDA program, which is your cash transfer. However, we have decided that the amount of cash will depend on the poverty status of the beneficiary if we take a look back on our Phase 4 box. In openIMIS, we can create multiple tiered packages using the services or items management functionality, and this is normally done by specific service administrations. A list of all registrant statuses can then be generated using a reporting functionality, and this list can be forwarded to third-party notification services such as calls or SMS brigades, house-to-house information teams, as well as onboarding teams. Following enrollment, notification, and onboarding, the next phase in the delivery chain is the provision of benefits and services. Strictly speaking, this phase can be categorized into provision of cash versus provision of services. However, for this module, we will focus more on the provision of cash payments in what is often referred to as government-to-person payments or G2P. While G2P is derived from government-to-person, for this particular module, we shall use G2P to describe any provider-to-person payment system. G2P strategies have had several iterations of improvement, with the COVID-19 pandemic being an impetus to rapid transformation of many ongoing G2P schemes globally. G2P systems traditionally are implemented with in-person, single program to single provider systems. In the advent of modern technology, electronically assisted and virtual payments became more available and accessible. And single program to single provider systems eventually evolved into many program to many providers, where a single platform can link beneficiaries of multiple programs to their preferred payment providers. We should also take note that not only is Phase 7 a crucial phase in the entire delivery cycle, but this phase may also be a recurring implementation cycle. We'll talk about recurring cycles later in Phase 8 and 9, Beneficiary Operations Management. Payment through bank accounts of beneficiaries is a common G2P strategy. In Indonesia's PKH program, the Ministry of Social Affairs uses a public financial management information system to directly transfer payments to bank accounts of beneficiaries. A similar strategy was used in Cambodia's ID Poor program, where in both cases, the cash can then be withdrawn directly from the state-owned banks or through ATM machines. Another mode of cash transfer is through mobile payments through e-wallets or phone-based payments where users receive cash benefits through their e-wallet accounts or through SMS notifications, respectively. The former strategy was used in Peru, while the latter was implemented in Togo's Novici program. By the way, electronic wallets or e-wallets, mobile wallets or digital wallets are electronic devices, software, or online services that enable users to conduct financial transactions using digital currency. That is, sending and receiving digital currency using digital currency to purchase goods or services. Lastly, cash in hand or direct cash provision through on-site or house-to-house payments remains the preferred cash transfer mechanism in many cases. In Sri Lanka, all emergency cash transfers were done using this approach. Several countries in the region have utilized multiple modes of cash transfer mechanisms. Pakistan's BISP beneficiaries have made use of e-wallets and bank transfers at ATMs or point-of-sale systems or POS. The Philippines SAP programs made use of bank payments through financial service providers or FSPs, mobile payments through e-money issuers, and cash-in-hand payments, as we mentioned earlier. It should be noted that provision of multiple avenues for cash payments have not been studied in greater detail, and its discussion is beyond the scope of this document. An important consideration in the selection of payment systems is the interoperability of such systems within their own service network or across different service providers. For instance, a single ATM card can be used across different ATM machines, even from different banks, since ATMs and point of sales terminals generally have higher interoperability. On the other hand, mobile payments have poor interoperability across different platforms, which is more evident in countries in East and Southeast Asia. Moreover, interoperability of registries with payment systems is a fundamental recommendation among multiple studies. Guide questions. Which evolution of G2P payments do you have in your country? And which G2P modality is the most feasible one to implement for your particular use case? Let's go back to our scenario. Let's assume that ARDA has no existing G2P system and it was decided that the program will adopt a G2P 2.0 system due to a collaborative agreement with ARDA's public bank or ARDA Bank to disburse the cash through bank transfer with ATM availability. Beneficiaries with no existing bank accounts or those who won't be able to create one will be given cash in hand via the program's temporary pay points. openIMIS service provider management functionality will register ARDA Bank as well as the pay points as service providers for the ARDA program. The claims management, review, approval functionalities can then be used to generate the payroll list as discussed in Section 4. openIMIS interoperable features ensures that the payroll list can be verified using other registries, for instance, national IDs or bank account information. Lastly, the monitoring and reporting function can be used to generate timely reports to guide the program managers and service providers on the status of program coverage per sector. Inasmuch as the first phase of the delivery chain is oftentimes neglected, the last phases are also often overlooked. For the purposes of this discussion, we will refer to phases 8 and 9 of the delivery chain as the Beneficiary Operations Management or BOM, as coined by Chavez et al. In the source book on the Foundations of Social Protection Delivery System. The main activities involved in the BOM stage include review of the beneficiary and benefit package data, redressing of errors encountered in the enrollment and service delivery phases, review of the adequacy and compliance of the logistics and other relevant processes, consistent monitoring of the conditionalities of the beneficiaries, and provision of grievance redress mechanisms or GRMs. This stage focuses on the outcomes rather than the direct turnout of the program and is usually only prioritized after program criticisms from the press and other stakeholders. In recurring programs, the inputs of this stage come from the preceding phases of the delivery chain, while the outputs often include modifications of both the beneficiary list as well as the benefits packages being offered to be implemented in the subsequent cycles. Let's look at specific examples of beneficiary operations management by different programs. The Philippines 4Ps utilizes a bimester beneficiary update system or BUS, which enables beneficiaries to update their information in the program, such as correcting of basic information, reporting of deaths of household members, or changing of servicing health units. Now, similarly, Mexico's Prospera program makes use of the first payment period of the year for beneficiary information updates. Another aspect of BOM is the constant and consistent monitoring of conditionalities. Indonesia's PKH program and Pakistan's BISP both adopt a quarterly compliance period for their education cash transfer schemes, with the latter program's non-compliance notification being coursed through SMS or even home visits. Monitoring of conditionalities, particularly before the start of each recurrent cycle of payments for cash transfer schemes, helps in exit decisions of the beneficiaries. A key enabler of cash transfer programs is the inclusion and enhancement of a mechanism for grievance redressal. This enables all stakeholders in the program to exercise their voice. Sri Lanka adopted an in-person grievance mechanism where people were asked to report to the local village or divisional secretariat office for their grievances. In contrast, Togo's Novici program opted for a call center approach. The Philippines SAP program received hundreds of thousands of grievances through multiple channels such as SMS, emails, and other platforms. SAP utilized the four-piece grievance redress mechanism as well as other e-platforms such as iReklamo and Usap Tayo. The processes involved in GRMs form their separate framework. For a more comprehensive discussion on grievance redress mechanisms in social protection delivery systems, we recommend Chapter 8.5 of the sourcebook on the Foundations of Social Protection Delivery Systems by Lindert et al. 2020. Guide questions. In your use case, how many cycles of each cash transfer will there be or should there be? How often will monitoring of conditionalities be done, and how can people report any grievances they may have regarding the program? Our RDA cash transfer program will have 2 cycles of payments at the end of each month of the proposed 2-month lockdown. Compliance checks, updating of information, and even exit decisions will be done between the 2 scheduled cycles. openIMIS functionalities, as described in the first phases, are crucial in these latter phases of the program. These functionalities will enable the quick review and validation of the beneficiaries after the first cycle in preparation for the second cycle. Additionally, a grievance center will be set up to accommodate grievances through in-person visits or calls. openIMIS can facilitate grievance management through validation of the credentials and enrollment of the complainant, as well as provision of contact information of to-be-notified beneficiaries to the grievance center to answer their queries. The administration feature can also give limited permission to officers of the grievance center for access to such important but sensitive information. Before we end this video, it is worth looking back at the delivery systems framework that we used. Again, remember that the framework is divided into 9 phases. The authors also divided the 9 phases into 4 more generalizable stages. We have reached the end of the long section 5, or part 6 of our module lecture series. In our last video, we will try to wrap up the previous lectures and come up with some recommendations. See you then! Welcome to part 7, the last video of the lecture series. In this video, we will try to summarize the past 6 videos and review our current action plans as suggested from the guide questions and previous scenarios. I will also share the references used in this module for your use. If you have not yet finished watching parts 1 through 6, I would recommend viewing them first. But if you have, then let's start the end of the module. In the prologue, we described what the module is all about and provided a roadmap into the learning objectives, expectations, and recommendations of the entire module. In Section 1, we discussed openIMIS as a free, open-source, modular, interoperable management information system software which is used primarily for health financing and is regarded as a digital public good. We also discussed its use by several countries, mainly in the African and South Asian regions. We also enumerated the main features of openIMIS, including registration and beneficiary management, claims review, approval and management, service providers and services management, monitoring and reporting, and administration of registers. In Section 2, we discussed how the COVID-19 pandemic has triggered governments worldwide to employ or enhance digital health technologies to support their health systems. Such uses for technology involve telemedicine, mobile technology, and electronic health records. We also discussed information systems as another tool utilized in mitigating the effects of the pandemic. These systems have found much utility in providing efficiency and timeliness of COVID 19 social protection schemes. In Section 3, we focused on cash transfer as a common strategy for social protection as well as mitigation strategy for the economic effects of COVID 19 lockdowns and restrictions. In Section 4, we discussed how Gambia has utilized openIMIS to facilitate its COVID 19 cash transfer scheme. Given the short time to implement the program, Gambia was able to take advantage of openIMIS features and characteristics as well as its existing social protection program to deploy NAFA Quick, a 4-month cash transfer scheme to benefit more than 78,000 households in the poorest Gambian districts. In Section 5, we utilized the delivery systems framework in order to better visualize how openIMIS can be utilized for a specific cash transfer scheme. This framework is composed of 4 stages divided into 9 phases: outreach, intake and registration, assessment of needs, eligibility and enrollment, determination of packages, notification and onboarding, provision of benefits, compliance and updating of grievances, and exit decisions and outcomes. We then discussed specific functionalities of openIMIS that can be used to facilitate the processes involved in each phase. We then hoped this exercise can promote the use of digital information systems and social protection schemes for COVID 19 and beyond. Throughout the entire module, we have discussed how utilization of digital information systems such as openIMIS have been identified as an important enabler of the delivery chain, specifically for cash transfer schemes. At present, some cash transfer schemes rely on information system only as repositories of data rather than to automate processes. Active utilization of enrollment and reporting features of such systems, particularly on the front end of the program rather than late in the process, can contribute to program efficiency. The importance of adoption scale and community import should also be a consideration. And utilization of interoperable systems, especially for multi-departmental programs, would also contribute to better program monitoring and decision making. Additionally, newer updates on the capabilities of information systems, such as openIMIS' upcoming AI-based claims adjudication system, can promote more efficiency through automation of some steps in the delivery chain. Given all these recommendations, program managers should be able to utilize updated and dynamic management information systems to facilitate their social protection programs more effectively. Here is a list of the references used in the module. Again, for added information and some key definitions and explanations, I would invite you to read through the reading material for this module, including in text and the footnotes. Try to answer the knowledge checks included in the manuscript and make a copy of the delivery chain mapping worksheet so that you can use openIMIS to start planning your emergency social protection programs. And that concludes the module. Thank you very much for watching, and I hope you've learned something practical and eventually useful.
Alright, so that is the last of our videos. And of course, I would like to thank our speaker, Dr. Julius Migrino, for preparing this module.
Thank you everyone for staying in, even though it was a very long, comprehensive, and modular section. So, as you can see, the format is rather different from our usual in our workshops or webinars.
Dr. Julius, congratulations. I am completely impressed with the output, very clearly done. And I think you actually designed this to actually be delivered in segments.
Yes, sir.
So
Yes.
good thinking ahead of what will be required. Um, of course, what we will do after this presentation is we will actually really cut it up into separate modules in the AHIN learning system, and maybe if you still have the energy, and maybe we can have the community of practice also participate as the first participants of the e-learning module. We can start adding some other exercises in between, like your delivery chain, which I think is innovative, and it becomes clearer when you start using the tool for specific use cases.
Mm.
So, do you have any while you were creating the program, did you have any inspirations about what might be next? Given that you started with a tool, and
Mhm.
then we have the situation of COVID-19, and then you try to mix the tool with the situation, and
Mhm.
you did a wonderful job making the connection. Um, Maybe we can even use the course for preparing for the next pandemic,
Yes, sir.
because the tools will be reusable. What will be your plans for San Beda? I mean, that's your home court, and how will you embed this within your university? Over.
Right now, sir, the plan is similar to what you put in the chat. I will be integrating it to our currently we have our medical elective in third year in San Beda University, and we actually started introducing health informatics already, and even openIMIS to our I think the past two batches of third year medical students. But as we just finished this particular module, I think this is a more hands-on, a more tangible module that they can work on so that they can actually, aside from learning about the technical nature of openIMIS, they can actually make use of the technology itself to for something more tangible or more practical.
Thank you. Chat, maybe we can open the floor for people who have questions. They can raise their hand. We Have you taken control already of your demo server, Dr.
I already accessed it, sir, but as I think my permissions there is as a student, but I've already looked at the content.
Yep. We can increase your privileges. We actually want to transfer the whole cloud structure to the schools, so that you can understand how it works, how to install, reinstall. And we have Ashish here in the call. He is one of the technical experts from Nepal who helped set up those servers. He also has a webinar on how he was able to set up the servers.
Mm.
In UP, what we plan to do using your material, of course, with your permission, I will ask the students to do role playing. Like, I will
Yes.
ask them to pretend that you are a registrar, and then this other student will be a patient, and the other student will be a healthcare provider, and then maybe they can switch every week or every 2 weeks, so that they get a view of what happens and what is the experience of a insurer, the registrar, the provider, the doctor, and the patient. And I think once the stakeholders understand the other views, they will be more accepting of health insurance, and once you know the challenges of the health insurer, then you become more forgiving of the insurer.
That's
But you
true.
also know when it's your turn that you have to do a good job in providing health insurance to the citizenry.
Yes, sir. I
Okay.
agree. That's a very good idea, sir, on how it will be implemented. That's actually one of my I guess ideas also. Really hands-on, based on the different roles. Because right now our studentry would be just focusing on being a doctor and what are the experiences of a doctor. But in understanding the health system, the I guess exposure to the different components will be of help to them also.
So let's share notes, your implementation in San Beda and our implementation in UP. And then maybe we can also invite Dr. Sharma from St. Luke's.
Yes,
And
definitely.
then I propose, under your leadership as the primary investigator, to submit another proposal to GIZ for another round of funding for whatever we think is the
Yes.
next phase of this project. And with that, again, with the deep heartfelt gratitude to Dr. Julius. I'm so proud of you. He was my former student in the medical informatics elective, and now he's really hardcore. So I'm happy to see you pouring yourself into the field. And thank you, everyone. And I hope that you will have a good night. Please keep in touch and we'll keep you posted on what's going to happen to this course. Thank you, Dr. Julius.
Thank you, Dr. Alvin. Thank you, everyone.
Good night, everyone. Thank you, Dr. Jean, Dr. Noel, my classmates. Good night.